Welcome to Research Perch from the Massage Therapy Foundation. Short, practical insights into massage therapy research and how it can benefit your practice.
Hello, I'm Robin Anderson, president of the Massage Therapy Foundation, and welcome to another edition of Research Perch. Today, we're talking about the results, or sort of the end results and discoveries from Project COPE. This is part 2 of a series that we did earlier. I guess it's been about 2 years, hasn't it? So where you have started this project, and it's unbelievable sort of how things, sort of develop into great research just from things happening in the moment. So I have 2 of the researchers here with me today, Dr. Blair Kennedy and Smith Heavner. Welcome, Anne. Welcome, Smith. How are you?
Doing great. Thanks.
Doing great. Living the dream.
Yeah. So before we get started, I'd kind of like to sort of have one of you set the stage for Project COPE, how it came about, just to kind of refresh everybody's memory. And then we'll kind of get into talking about what's happened since then.
Well, it all started coming back from an AMTA board meeting, I think for me, when we were looking at all of the pandemic starting in March of 2020. Like, we'd already been watching it in New York and everything else. And shortly after I got back from that, Smitty and I were having a conversation about what I was seeing with the massage therapists starting to get nervous and people having to shut down. If you remember that angst at the beginning of the pandemic and that real fear, because we really didn't know what was going on. Yeah. And then Smitty and I just started talking from his end. I'll let you take it over from there.
Yeah, absolutely. So I'm a registered nurse. And so I was hearing a lot of anxiety about the impending crisis, about a lack of preparation, concerns about resources and staffing. And so Anne Blair and I started talking about, we were hearing things that sounded similar, but there were definitely very different perspectives. And we realized we had a very unique opportunity to look at nurses and massage therapists. Both of us feel very strongly about championing our professions, and we realized there's never been any study that's kind of looked at what might be similar between the two professions. There's plenty of research showing that massage therapy practice can be helpful in critical care settings, which is where I practice. I'm an ICU nurse. And there's plenty of evidence out there to suggest that massage therapy can be helpful for burnout and moral distress. But there hasn't been a lot of data collected about massage therapists' experience of a crisis. There certainly is a lot of information about them helping out, being involved in Hurricane Katrina, showing up to help with first responders after 9/11. But no one really ever captured their stories. So that not only was there a chance to look at the two professions who are very focused on facilitating health and wellness, as opposed to delivering cures like a physician would be, that there may be some philosophical similarities between the two professions. So maybe there's something similar about the way they experience a crisis. But also there's this really unique opportunity to actually capture massage therapists in a way that they've never been captured and understood before.
Yeah, I found that very interesting. Oh, sorry, and
Go ahead.
I just wanted to point out that the topic moral distress that you brought up, how interesting that topic is, plus the fact that, yeah, you're right, there hasn't been much real hard research done on how massage therapists or nurses have sort of suffered this kind of burnout and so forth in terms of looking at inward. It's been very anecdotal, not really hardcore research, and a pandemic such as this certainly presents that opportunity in different perspectives, which obviously you both recognized.
Absolutely. And also within my other line of work, which is being an instructor at a medical school, I was also seeing what was happening to my students being pulled from the clinical environment, and also my friends who are working in the healthcare system as we were starting to see things ramp up. Here in South Carolina, at least. And so within 3 weeks, we got a team of about 11 individuals together from across multiple institutions. And we were working with another group who'd been doing some similar work at looking at burnout and moral distress in the emergency department, and we brought them onto our team. so that we could kind of use the same measures as they were using. So then we could compare our studies later if we wanted to. And we got this survey launched and got website up and everything just really, really quickly at the beginning of the pandemic. And then started gathering data starting, I think it was April 16th was the day we launched it.
Wow.
Originally. Yeah.
That's fast. That is fast.
It was, and that was through IRB as well, right? I mean, it was super duper fast. Yeah. And it was just fascinating how quickly everything got going. I think it was because and I'm not going to speak for you, Smitty, we needed to do something, or I needed to do something. It felt like I needed to do something for the profession and for the pandemic and watching what was starting to happen. And so for me, it was also very healing in a way to be doing something.
Yeah,
absolutely. I absolutely agree. And I think, so Ann kind of alluded to this, but we ended up expanding beyond nurses and massage therapists. We actually capture 21 distinct healthcare professions.
Wow.
Everything from social workers, physical therapy, radiology technicians, acupuncturists, chiropractors, physicians, nurse practitioners, and then many subspecialties out of those. Significant representation in critical care, primary care, as well as the allied health professions and the complementary and integrative professions such as massage therapy. We also had a number of counselors and mental health professionals as well. So just a very, very diverse, very broad sample of perspectives.
That's awesome. I was going to ask you that, what types of professions actually responded to that survey. How many participants did you end up actually in your sample size?
I can look that up. It's been a minute since.
Yeah, we had quite a few. I know we had a lot, but there was also this, we had the most of massage therapists.
Yeah.
So thank y'all.
So just under 1,300 unique respondents.
Wow.
About 45% of those were massage therapists.
Yeah.
And then we had 21% or 273 nurses representing the sample, and the rest of the professions made up the rest. So almost half massage therapists, about a quarter nurses, and then 25% other professions, which kind of tracks with what we were expecting. We recognize that those professions who were being displaced and being pushed out of the clinical environment would be most likely to actually have the bandwidth to respond. But we did get some very interesting responses from all professions.
Yeah, that's really cool. And this also expanded beyond United States borders, correct? You had people in other countries responding. What other countries participated?
There were several we had a number of respondents from Australia, several in Italy, and across Europe. I think we had one or two respondents from Africa originally, and that actually sparked an interesting project where we launched a subset of the project specifically in Africa. We have colleagues in, what university are they at?
Harare. They're over in Harare. So in Uganda is where that was started. So we got some initial data from there too, as well. But we also had several from Canada too, right? So we had, but that was kind of where we got a lot of the data from.
So North America well represented, but definitely across the ponds and so forth, and getting some other data. That's fantastic though. It's great to see how they could have responded in different countries, because the pandemic impacted different countries differently. So that also could have had a ripple effect. And also to your point, Anne, about educators, I was feeling that too. My students were being kicked out of clinicals, but then of course the instructors were stressing about their students, like you were saying, what do we do next? What do we do next? So that moral distress goes beyond just practitioners, it goes into education as well, which is probably a whole nother study in and of itself. So, all right. So with this information that you found out, if you could share with me maybe one highlight or one element that you found was astonishing to you that you didn't anticipate as part of the study, one of the discoveries that you've had.
It's your dissertation.
So I think some of we certainly had lots of captures of how stressful things are and how hard things are. I think there were two big things that really stood out to me. One was the level of isolation that especially acute care providers put themselves under. Not just isolation in there's isolation that came from some of the politicalization of the pandemic, but there was also where people voluntarily isolated themselves from their families. And we knew this was happening. One of the reasons we kind of started this was we started hearing those anecdotal stories about people sleeping in their garage so they don't get their family sick.
Oh, yeah.
But the stories that came were so rich. I remember really specifically, there was one nurse who actually, she was a massage therapist, cross-trained, became a nurse just before the pandemic. And she shared a story with us where she was talking about, she would go on these long walks by herself, and she would sit in other sides of the house away from her family. And I remember very vividly, she was sitting in her bathroom telling us this story. And I remember thinking, like, this is someone who cares so deeply about their patients, is recognizing how much risk she's at personally, recognizes the risk it's putting her family at. And rather than walking away from the profession, rather than doing things to make that more safe, what her choice was to remove herself from her family unit. And that what an incredible moment that was, to sit there and sit with her words as she told us that was just really impactful. I think we watched the video 2 or 3 times as we were analyzing it, just because we could, every time we would start to try to think about her words and start breaking things apart, we would just get lost in what she was saying.
Wow.
There was another professional who was actually they and their partner were both emergency medicine practitioners. And they talked about what it was like to try to balance that work and try to have some semblance of normalcy in their relationship, but were completely consumed by the work itself. The other thing that really stood out to me was the resilience. We saw people engaging in certainly unhealthy coping mechanisms. There was a number of people that talked about increasing or starting smoking again, or about eating a bunch of junk food to try to cope. But we started seeing it first in massage therapists, but we started seeing it in acute care professionals as well. People talking about things like gardening, walking their dogs, or finding ways to volunteer. There was amazing how many people in the midst of a crisis, if you're a massage therapist, I mean, they were at risk of losing their livelihood. Some of them talked about they weren't sure if they were going to be able to pay their mortgage, their rent. Several people it sounded like they were very close to a housing crisis, but they went out and took time to help and to give back in some way. It really speaks to, and we saw that across professions. And it speaks to the reality of the people that are doing this kind of work are just, I mean, frankly, they're just built different, right? I mean, we don't have, and it's kind of an anecdotal conclusion, but we don't have comparisons of lay people to this, but you wouldn't expect a huge majority of the sample to be so concerned with, I need to find a way to give back, I need to find a way to help. And it was very, very moving and touching. I think for both of us, I stepped away from the bedside to move into a research role before the pandemic, and Blair hasn't practiced in a number of years. And so both of us came in with this like feeling of we're cut off from this and wanting to help. And we realized how similar we actually were to all those people, and that this was a way that we actually could give back and help, and help capture the story so that people would understand what this experience was like.
Wow, that's really impactful. I mean, just unbelievable, the similarities, but also that sense of wanting to be a part of something bigger than you and giving back to it for the sake of your own love of humanity and being able to give something back to everyone. And also taking that step of like isolating yourself from your family, especially in the early part of the pandemic, because we really didn't know how it affected people and how it could affect people. Now, did you see any trends as the pandemic went on when vaccines were started? Was there a trend that sort of changed that perspective a little bit?
Yeah, so our sampling wasn't really powered to really do a longitudinal analysis in that
Okay.
way, and we didn't uh, we didn't get as many people capturing the data long term as we wanted. We set it up so that people could tell us their information every week, but what we did see, and I'm working on an idea to do a sensitivity analysis in the qualitative data,
Sweet.
but at least anecdotally, when we look at the timestamp of the video blogs that people submitted, when those vaccines became available, we can sort of see the signal when as the studies were coming out, as we were thinking about the first FDA emergency authorization, and when the vaccines actually came out, you could start to see people kind of change. And there was one nurse in particular who talked about getting her vaccine, and about, this is a moment where you can see some of the weight kind of coming off of her. She didn't dig into it. As I really wish we had an in-person interview, because we could have probed a little bit, but it was a video recording, and you could see when she says, "I got my vaccine," there's this moment of just kind of and
Yeah.
she just kind of let go of some of the stress and some of the concern, because as a lot of us felt like this was this final moment of, okay, I have a little bit of protection. There's something that I can do. There's something that my patients can do to help protect themselves. And Blair, I don't know if you want to add anything to that.
So I think one of the things that Smitty keeps talking about is we were able to see this, right? Because it was these video blogs.
Right.
And that, I think, was one of the most impactful things for us. So not only did we have this quantitative data from these surveys that were being sent out, but also the people who submitted their stories. Those were some of the most powerful and impactful things for us, was being able, we haven't really watched them longitudinally to see how somebody progressed, like pick a specific participant. But as Smitty also alluded to, that's something that we're kind of interested in, to see how people were progressing through for the people who submitted multiple ones. Mm-hmm. But just to hear and see the stories, it was the seeing and the watching the individuals change. You could almost tell their professions just by how they presented themselves in their videos.
So she's laughing. We made a game of that in the analysis, where we would try to predict in the first 30 seconds whether this was a nurse or massage therapist or something else, and it would have been fun to capture that, to see how good we are, because we could sometimes we could tell pretty clearly by their disposition, or there'd be some clues in the background to let us know, what profession they might be.
That's great. I was going to ask you all if you had added or changed things as you went along. So I guess in order to make the research light and at least a little bit interesting, you got to make some challenges for yourselves along the way. So, but what other things did you pivot on or have to change as you started collecting this data?
Yeah, it's a great question. So we saw about 6 months in, we saw kind of a drop off in our people participating in the weekly surveys, and so we actually spaced out and stopped sending them every week, sent them every other week. We decided to do a time to a survey where we asked put some additional validated measures in that we hadn't asked originally, because we were starting to see something in the data that told us we might need to do a little bit more quantitative data around burnout, around some of the sources, around some of their ethical concerns. Mm-hmm. And so we made little changes in the survey we were collecting. But I think the biggest shift was we set this up as a mixed method study. We knew we were going to need both. Yeah. But especially as Ambler mentioned, I did my dissertation on this and defended last year. But the biggest shift, I think, was that we put a lot more emphasis on the qualitative. We realized we were capturing stories that we hadn't seen in the literature before. We were capturing perspectives that weren't out there, and we started to shift to think, let's prioritize this, and we started letting go of worrying about the quantitative data that we were collecting as much, because we really wanted to capture the information. There's one quote in particular that I remember really kind of pushed me in that direction. Anyway, this is the one about the quarantine station. if you'll indulge me, I'll read this. So this was an emergency medicine professional. They never disclosed exactly what they were. We think they were either an emergency medical technician who works in the ER or an ER physician. We don't think they were a nurse just based on the way they were talking, and they didn't choose nurse in their survey. They chose other. But this is what they said. And so this is a young person sitting on their couch. Their hair is wet. It's kind of dark in the room. There's a window behind them, but the curtain is drawn. They're wearing kind of a wrinkled shirt. And so, as Blair was saying, like being able to see someone was really powerful. And I remember really specifically that they had lines around their mouth. And I can only assume that was from a respirator. But they said, we have a quarantine station set up at our front door, which is a constant reminder when I'm home or when I have a day off that we're working the front lines in the middle of a pandemic. And we wipe everything down as soon as we get home. We strip our clothes. They go right into the wash. We go right to the shower before we do anything else when we get home. And it was, I mean, they were so focused on this process and so intent on doing this work. And we don't think there was anybody else in the house. We think it was just them and their spouse that both worked in emergency medicine. But that level of concern and vigilance, we'd heard those anecdotal stories about people sleeping in the garage, and people, we all had friends that were, stripping down in their driveway or they came into their house, but they capture that data, and to be able to really analyze that and really understand that and start to, lay the beauty of qualitative research is laying that foundation so that we could develop some kind of survey to really capture that experience in the future. But it was this moment, I remember sitting there and watching that video, and I just like stopped and sat with it for like 30 minutes, just thinking about that experience, what that person had just told us. And it shifted. It was actually the quote that made me shift. So the first two papers of my dissertation, I actually shifted to focus on qualitative research instead of being a balance between quantitative and qualitative.
Wow, that's really interesting. And again, very impactful. So my daughter works with adults with differing abilities, and she was working through the pandemic and had this similar type of thing where she had roommates she had to strip down before she went in her house. And, again, people with that type of background, they don't understand what's going on and why people aren't seeing them or why they're not allowed to see their family or their loved ones. And yeah, it's unbelievable how much this impacted. And with some of the sort of stressful events that we've had in previous history, like you mentioned, Hurricane Katrina, 9/11, those were unique to either a city or to a country, but the pandemic impacted us all over the world. So that made it even more expansive. Did you discover anything from different countries that were different from what we found out here?
I don't think we had enough power. Like there weren't quite enough responses, and we didn't actually even analyze it specifically that way. Mm-hmm. So unfortunately, can't really answer that question. Okay. But I think some of the other interesting pieces in here really come from, and I just lost train of thought. Sorry, it just left. That happened, right? Yep. I had it and it's gone. It'll come back maybe. Sorry. Yep.
That's okay. That's all right.
Yeah. So we in the qualitative, and qualitative analysis isn't really designed to do that kind of comparison, but we were paying attention to, because we got a fair number of videos from Canada, for example. Mm-hmm. And we didn't see any major themes that were just absent from that. I mean, we continuously heard people talking about a lack of personal protective equipment. We heard people having concerns about the government's response and policy. And something that was very pervasive, and we actually ended up developing a whole theme around it, was that politicization of the pandemic itself. Yeah. And also the rest of everything that was happening. I mean, it's been a very eventful 2 years. Yeah. I mean, the election, the Black Lives Matter protests, right? The wildfires in the Western United States. There's been a lot happening, and we saw people really wrestling with trying to figure out how to prioritize. There was one person that talked about trying to figure out how to worry about air quality while also trying to worry about the spread of pathogens because they're worried about being indoors with too many other people and spreading COVID versus going outside and being exposed to all the smoke from the wildfires.
Wow, that's a toss-up. That's absolutely a toss-up. Oh my goodness.
So that's what it was. That's what I was trying to get to, that my brain left. It was all about the context of the political. Yeah. So you clearly were sharing the brain at the moment. I appreciate you taking it and running with it. Helpful.
That was another interesting experience. We realized how much Blair and I have gone a little bit into the hive mind a little bit sometimes, but it was interesting to see. Blair and I would look at a video and we'd be 100% alignment on how we're going to code this, but we brought another PhD student in to help code, and sometimes she would be an anchor for us, because we would get way out here, getting way into trying to parse the theoretical foundations of a person's professional identity, whereas the student kind of bring us back to the ground a little bit.
It was very helpful.
Well, having multiple perspectives definitely helps keep you grounded, no doubt about it. Mm-hmm. What about demographics? More males, more females, more age range? Any distinct differences or prevalences?
Overwhelmingly white women. Which is not overly surprising, given the both nursing and massage therapy are predominantly white women professions. We had a really undersampling of many ethnic groups and races. And so it's something that is a significant limitation of the study, because certainly someone who enjoys the privileges that Blair and I do as white people is going to experience things a little bit differently. We just didn't see any surprises in age ranges. There certainly were some extremes. There was one person who claimed to be, we actually ended up censoring it, I think, because they claimed to be in their 90s and still a working professional. And we weren't quite sure about that. But also, I remember their years of practice didn't line up either. But I think most of the professions, their ages hovered in the mid 30s to mid 40s for the median and mean. Not a significant amount of skew. We did have a large sampling of early career professionals, especially in acute care. Massage therapy tended to be more veterans. I think our average years of practice is around 10. But for nurses, they were frequently 1 or 2 years out, or they started during the pandemic.
Yeah. Which that was sort of something that was lifted during the pandemic, is if you were a nursing student and you were almost finished, that they welcomed you right into the healthcare setting because they needed those people. Mm-hmm. So yeah, whereas massage therapists, we were delayed probably a few months before we were allowed to practice again. And of course that depended on the state. So, and the PPE that you could get as well. So
Right.
You've got to tell me, when are we going to be able to see this published? Have you been submitting it to journals, or where are you at in your process? Because we're dying to see it in publication. Yeah. So my dissertation is available publicly, and I can share the link with y'all.
We are working on, I think we're also wrestling with our own burnout, and we are working on submitting the first papers to publication. The first aim, which is exploring all the participants, working on submitting. We have a number of target journals working on formatting that. And then our second paper, which is analysis between nurses and massage therapists. We'll follow that up very closely with the first paper. And of course, we have our third paper on hashtag evaluation. We do have one other paper that's already been published.
Yeah, I got to pull you back, because we haven't talked about hashtag evaluation yet. And they don't know what that is. And I want you to tell them what it is, because it's awesome. No, you go ahead. It's awesome. We created a new methodology.
Yes.
Okay.
So we realized we had a large volume of data, such that existing methods weren't going to let us really get at it and really understand what's going on. There are a number of rapid evaluation methodologies, such as rapid identification of themes from audio recordings, or RITA, which we actually used in the first paper. But we realized we also had the opportunity to include learners in this project in a very central role. And so what we did is we had 2 medical students, and we asked them to review videos as they were coming in. in part to sort the data, but also to look out for any danger signs. We wanted to watch out to see if there was anyone who is at risk of self-harm or anything like that. And we asked them to think about, if this was a video posted on social media, what would the hashtags be?
Oh, okay. Interesting.
Right, because I mean that's kind of the way of qualitative research works, right? You're taking a big thought and putting it into 1 or 2 words,
which many people did during the pandemic because we couldn't be in the same room together, and so that's how we communicated. Oh, that's interesting. So which ones did you get? Which hashtags did you find?
So they came up with a list of 200 and something hashtags altogether.
Wow. Okay.
And part of, we didn't give them a lot of structure, and we didn't build in a process to really condense those, because there was a lot of times where it was, one hashtag would be coping mechanism, and then someone else would have coping mechanisms, right?
Right.
And so we collapsed those down into about 17 categories, and they really largely lined up. We intentionally kept that separate from the qualitative analysis we were doing in the first 2 aims. And in the aim 3, we actually looked at those together, and we found that the students weren't as adept at parsing out things like moral distress versus burnout, right?
Okay.
And frequently they would use hashtag moral distress or hashtag burnout if the participant mentioned the word. Whereas us as the researchers, we would think about the context of what they were saying and then label it as either burnout or moral distress. We ended up collapsing those anyway. But they found a lot of the same things. They also pulled out this piece around the pandemic not happening in a vacuum, and the political context, environmental crises, everything else that was going on. They also talked about the politicization of the pandemic itself. And really interestingly, they also found this trend where nurses were more likely to isolate themselves, whereas massage therapists seemed more likely to try to find some means of creation making to try to cope with the pandemic. And so our that third paper is a description of that methodology, which we hope to expand and apply to other places, because we found that not only is it a great way to help sort data very, very quickly, a large volume of data. We had, I forget how many dozens of hours of video blogs. We had just under 300 video blogs.
Wow.
And each of them, on average, they were about 5 minutes. Some of them were 12, 15. One of them was 35 minutes, I remember. It's huge volumes of data, but we were able to sort it very quickly in near real time. So that as we were looking for other abstracts, as we had conferences that wanted to look at this information, we could search the hashtags and let's pull out the massage therapists, let's pull out the nurses, let's pull out anyone that talks about the politics, let's pull out anyone that talks about PPE. And we're actually pretty good at identifying those videos and getting them sorted into the right categories. But they also found that they were able to, at a high level, find a lot of the same themes. So not only is this a powerful sorting and evaluation tool, we were hoping it has potential as an actual research methodology to be another rapid evaluation technique to get at high level information when you have a large volume of data to deal with.
Wow.
Especially with people who aren't familiar with qualitative research,
yes,
as these medical students weren't.
Yeah, they're probably used to more quantitative than. Yeah, exactly. They
get 1 hour of what is qualitative research, and one of them hadn't even had that yet.
Oh, wow.
I teach it in the 2nd year.
Okay. Oh, wow. That's interesting. Very, very interesting. Wow. All of this information is just going to be so unique to be able to read. We can't wait to take a look at it. I want to touch upon one more topic before we kind of wrap things up. Please describe the difference between burnout and moral distress, because we've talked about this a lot. But clearly those were 2 distinct areas in which you separated this. So could you sort of characterize the differences between those 2 topics?
Sure. So I'll also add, Ann Blair was on my dissertation committee, so she hasn't quite gotten out of that role of kind of pushing me up to answer the question. Burnout syndrome has been well categorized in literature for a long time. And burnout is a state of emotional exhaustion where someone who does some kind of people work, whether that's healthcare, social work, is just kind of run out of reserves, and there's a component of a lack of self-care, a lack of replenishing your own needs and building your own energy back up, and you get to this state where you start to lose your empathy and you start to lose concern about situations. There's a closely related term called compassion fatigue. And part of the problem we're also dealing with is these are not always clearly delineated in the literature. There's many studies that will use burnout, compassion fatigue, and moral distress kind of interchangeably. So this is the way we see them as conceptualized and what we think based on the literature that's available. So that's burnout is a state of emotional exhaustion. Compassion fatigue is where you start losing your care, losing the ability to care about other people. Both of these are associated with increased risk of medical errors. They're actually associated with increased risk of automobile accidents as well. Long term, they're associated with an increased intent to leave the profession altogether. Moral distress is in some ways something that could feed into these, but it is kind of its own thing. And moral distress is that unique experience of knowing or believing you know the correct action in a situation, but something prevents you from doing that. And it's usually some sort of authority figure. So either a policy, a financial, or physical constraint. A lot of the really powerful literature around moral distress comes from a lot of the Ebola work, where you see people that have very, very limited resources, and there's a huge group of people that need help, and you end up having to triage and prioritize and give the care to people who are most likely to survive. And you see the practitioners experiencing this moral distress where they see these other people and like, I know I can help this person, but the policies we put in place means they are outside my scope. And so we can see really clearly how easy it is to blur the lines between these, and it's not, there's not really sharp lines to begin with. And that really is a good reason why the students probably weren't able to parse it very well, because they hadn't spent years reading the literature. But you can see these three distinct concepts of burnout being a state of emotional exhaustion, compassion fatigue being a lack of empathy, a lack of concern, and moral distress being that ethical outrage of I know how to help, but I can't for some reason.
Right. And those are really, even though they have similarities, there are some definite distinctions between them. So absolutely. This is just amazing work, and definitely work that needed to be done for the massage therapy profession, for the nursing profession, and many other allied health professions. Really, we can't thank you both enough for taking the initiative. I guess you just needed something to do during the pandemic, huh? So you just had to do some research. So
our full-time jobs weren't enough. Dissertation wasn't enough.
Yeah, right. Absolutely. One last takeaway that you can share with us today.
I've been talking a lot. Am, there you go.
Last takeaway. First, I just want to thank everybody who took the time to fill out and send us in their thoughts and agreed to help us understand what was going on. And I think that it was Research Perch, along with some other interviews that we did, that really helped pull in the massage therapists to do this, because we now have this great and amazing database of massage therapists that we can reach out to in the future. Hopefully they'll still be willing if we want to follow up with them later. So I wanted to put that out there. Thank you so much for participating in the project, if you did, and for reading about it later and listening about these stories now. What about you, Smitty?
I couldn't agree more. I think the other thing I'll add is so often in research, especially in young researchers, we worry about whether our work is going to be impactful enough, and everyone wants to have that earth-shattering publication. I think the big takeaway in the piece that I've shared with the students that I now teach is making a little step. It makes a huge difference. You know, we set out not to get published in JAMA or BMJ or anything like that. We set out because we wanted to capture these stories. We knew that someone needed to catalog this information so it'd be available for future generations and for future research. And it became a very fulfilling, very powerful process in and of itself. I think the biggest takeaway for me is that even if you don't think that you're going to shift the paradigm, if you have a research idea, if you have a research question, go for it. There's no harm in doing this. It certainly is a lot of work, and you need to have the passion for it. But don't worry as much about whether you're going to break the mold, and focus on doing what is right for the populations you're researching. Capturing their stories was the right thing to do.
Wow. That was great advice, great inspiration. Thanks, Smith. Thank you so much for joining us today. And Dr. Kennedy, thank you so much for sharing all of your experiences, all of your insight from Project COPE. We look forward to seeing all of this stuff published and its contributions to the massage therapy profession and allied health professions beyond. Thank you so much, everyone.
If you enjoyed this podcast, please consider donating to the Massage Therapy Foundation so that we can continue to bring you this and many other resources to increase your knowledge and improve your practice. Thank you.